Friends, when we look into prostate therapy and prostate treatment beyond medical management, where the medicines have not worked, and he is into refractory bladder outflow obstruction. The bladder outflow obstruction doesn't let him pass urine comfortably and freely, doesn't let the urine come out. And he is a case of bladder outflow obstruction because the prostate is enlarging, causing an occlusion and blockage of the urinary passage. It's time for him to get relieved and cured by a therapy, which is obviously always traditionally a surgical therapy. Since the era of open prostatectomy to having taken very large prostates robotically at Kokilaben Dhirubhai Ambani Hospital, where transabdominally, transvesically, large prostates of 250 grams to 400 grams could be completely enucleated without transgressing the urethra or the sphincter zones. And patients did completely well from day 7 till last few years. It feels that we need to stratify our therapies to different levels. TURP, which has been a gold standard of therapy towards clearing the prostate internally by resecting the prostate, something like you take a spoon and cut the coconut from inside and keep resecting its chips and leave the outer shell. What has been the therapy for prostate surgeries since time immemorial? Various armamentariums which have actually come in around, that was revolutionized best by minimally invasive therapy called the laser therapy, something which is used across the world and which has actually undergone revolution in terms of the fibers, in terms of newer lasers. So these are all surgical procedures. TURP is a surgical procedure. We continue to perform close to 20 to 40 per week at the Kokilaben Hospital. More patients are treated on medical management, but sadly, these many patients refractory, having a catheter completely obstructed, medicines not working, get referred by colleagues in general practice from this part of the city and from various cities from where they come to a larger megapolis because their sons and daughters work here and they have a catheter in situ which is not coming out. During this therapy and revolution came the minimally invasive therapy, a therapy which probably stands tall in a subset of individuals. And today, when we talk about it, the therapy which we talk about is prostatic urethral lift. That means a minimally invasive therapy which is without any surgery. There are no cuts, there's no resection, there's no laser enucleation in this, but in a named individual who understands the procedure very well. We normally take clips and clip the prostate in such a way that its occlusion, which is happening internally as a result of occlusion of the urethral passage, is clipped off and the prostate is then taken away from the midline. So let me explain to you what happens in prostatic urethral lift, which popularly has been called as a Urolift procedure. Individuals who have got a smaller prostate, though the US FDA approved this for up to 80 grams prostate and later on revised to a maximum of 100 grams prostate, which would need extra amount of clips to actually remove the occlusion with clipping the prostate. The ideal procedure has been for smaller prostates which don't have median lobe, and for individuals who sadly are on catheter, are refractory, voiding symptoms, and probably cannot be given anesthesia. So what's the benefit of this procedure as a minimally invasive surgery where there's no surgery? It's all about a telescopy, all about taking the telescope inside, assessing the prostate in advance. A lot of assessment has actually happened by a clinical examination called a digital rectal examination, by a sonography or by a transrectal sonography to give us an idea of a probable configuration of the prostate so that there's not a large median lobe. And once that is done and there is a consultation across the table in the Department of Urology where I sit and talk to you, we discussed the Urolift procedure where we can actually clip the prostate. A small prostate can also occlude. I always say the prostatic size does not matter. What matters is the occlusion internally. A 25 grams prostate can cause an internal occlusion, and a 200 grams prostate may still not cause an occlusion, but it could be a large prostate without the urethra getting blocked. So the size of prostate for the prostatic urethral lift surgery, which is a minimally invasive therapy, is about understanding that we will be able to clip the prostate to its external capsule and in such a way remove the internal occlusion by clips around, which is a short procedure, very well designed and planned with the innovation that has come into vogue at this point in time. At the Kokilaben Hospital, let me give you an example of few cases, but let's take two cases of last month. Mr. X, 86 years, old gentleman who was having refractory obstructive voiding for a very long time, was attempted medical treatment by his colleagues, his general practitioners and urologists in his city, and was undergoing the therapy. Sadly, the therapy was not curing him. That means he wasn't finding relief with this over the last 3 to 5 years, and he was in his 80s. The progression happened to such levels where he finally one fine day underwent a retention of urine and got blocked. This is a sad story as a complication of many prostates and many individuals who probably are not aware of changes happening with the medication and without the medication. That means if we are on a medical management, we are aiming to look at the flow getting better, the residual volumes get lesser, attempt to also shrink the prostate gland, which is more than 35-40 grams, so that that does not continue to grow using the 5 ARIs. So, in that attempt of improvement, this gentleman actually progressed to a retention of urine. Thereafter, attempts at removal of catheter and attempts at add-on medications and probably looking at combination therapies did not work, which means that it's an end of the road in individuals whose urinary flow is progressing towards lesser and lesser curve and probably getting obstructed with a higher residual volume to land up one day in a retention of urine. And therefore, a very important awareness drive from the Kokilabean Hospital Department of Urology is that we need to safeguard our urinary health by the knowledge of prostate and prostate issues, which touches men from 50s to 80s. And it's important for us to be aware that while the standard therapies are aware at the Kokilabean Hospital, where we do the holmium laser enucleation of larger prostates, enucleate it completely and pull it out. We do the resection of prostate by a TURP, a much faster technique in my hands, where I use a Nesbitt's procedure. We cut down the blood supply completely, so it becomes a minimally or least bloody surgery at all compared to very large prostates. But there's an era where it's a lot driven by colleagues across the table, the patients who look forward to minimally invasive therapy. So the minimally invasive therapy was chosen for patient number one, who actually happened to be a senior elderly gentleman in the society, but into refractory retention. When anesthesia fitness was looked at, he was not fit for any anesthesia with an ejection fraction of the heart close to 20-25% and multiple comorbidities where the anesthetist would not be able to give an anesthesia. So let's look at this individual who finally got into retention, but always used to empty his bladder some way by straining, pushing, taking a longer time, and finally is on a catheter. Being on a catheter, being a diabetic, started developing recurrent urinary tract infections and was advised a suprapubic cystostomy. That means he was given a chance to be having a catheter through his abdomen so that the lower urinary tract does not participate in this infection process, which has a new onset procedure happening to him. He refused that. He wanted to pass urine per urethra because otherwise he was physically fit. His cardiac situation and his comorbidities did not allow the anesthetist to give him an anesthesia for another 45 minutes procedure, which could be a TURP or a HOLEP. So he was taken for a prostatic urethral lift with an understanding that we are attempting to get his catheter out. So this gentleman was operated under local anesthesia. And the operation here was only a cystoscopic procedure where with under local anesthesia with minimal sedation, he could actually tolerate the entire procedure of 12 to 15 minutes where prostatic urethral lift was used for a 48 grams prostate with a very minimal median lobe, which means that we used those 4 clips and could stretch the prostatic urethra away from the midline, which was progressively the cause of his occlusion happening over years and decades. The catheter was removed 48 hours later, only because we wanted to ensure that every other aspect of his comorbidities stabilize around. He had undergone a urodynamics before the procedure and his bladder was still having a wonderful contraction. So as expected, but with keeping all fingers crossed, the catheter was removed and he passed urine as if he had never passed urine before. That means his prostatic urethral occlusion was removed. So for a subset of individuals who cannot be operated, who cannot undergo a TURP or a holmium laser enucleation or a thulium laser surgery for a prostate, an individual of this kind in the evening of life wanted to pass urine per urethra, was not able to. He was on dual antiplatelets, which were stopped 6 days ago with a low ejection fraction, with an understanding that the family had. We could actually clip this prostatic urethra completely and he did well. Coming back to a 54-year young gentleman, who otherwise is sexually active, capable and comfortable in his life and settled very well. wanted a minimally invasive therapy because there was no way out that his urinary symptoms were treated with change of medications, change of cities, change of urologists. He was attempting his best. His prostate was only 30 grams. Just 30 grams prostate. All uroflowmetries were flat and prolonged, taking a very long time with a high residual volume. He underwent change of various medications. His urodynamics finally showed a significant to gross bladder outflow obstruction, where the bladder was contracting very erratically, attempting to empty. But this was a secondary bladder outflow, secondary attempt to empty the bladder as a result of the bladder's excessive contraction, making him now go more frequently, pass little, sometimes leak urine out as a result of his severe urgency. So a very young man in his 50s wanted to get relieved, at the same time wanted to be continuing sexually active and was not keen for a surgery. He understood the implications of a Urolift procedure. The US FDA says that you should do less than 80 grams prostate. Ideal technique would be one where you don't have to do anything to a prostate which has a median low, because median low will be a challenge in this case, where we have to do multiple stacking procedures around. So this gentleman who had a 51 grams prostate on measurement recently, and the prostate measured between 45 to 50 grams in his last 3 years of progressive symptoms from early 50s, underwent a prostatic urethral lift by us. During that surgery, we again, over a matter of 17 to 18 minutes, could do a cystoscopy, could assess the prostate, which was already assessed with a transrectal sonography to see there was no median low. With a 51 grams prostate now getting an absence of occlusion, which has happened over the last decade, where his flow has gone down to a near baseline, grossly obstructed. Lucky had not got any urinary tract infection. But a lot of secondary bladder outflow obstruction symptoms had set in when the bladder was contracting erratically because of urgency frequency around. So I'm just talking of two cases in a procedure which has got limitations. The prostatic urethral lift or Urolift is for a very select class of population. Younger individuals want to continue to be sexually active. The prostate is not huge, but there is refractory bladder outflow obstruction where medicines are not curing him. The medicines is not getting him a cure. The way we clip these prostates in such a way that you clip it across and the prostate is removed from the central midline, and in that way, you probably help individuals to looking at that. Remember, the prostate in these individuals can grow in future, and therefore, many of them continue to be on 5 ARIs towards future prevention of trouble. So at the Kokilaben Hospital and Department of Urology, as we assess prostatism in men, lower urinary tract syndrome or LUTS in men, we look forward to understanding who could be a patient for watchful waiting, anything between 25 to 35 grams with a great flow, who does not have any symptoms, whose PSA reports are normal. We watch them very closely and be friends to be seeing them once in 6 months, once in a year, or also if there's a requirement. For individuals who have got a bladder outflow obstruction, from the very language they speak in terms of obstruction, in the language that they speak, that they would require medical management towards control the entire situation from a progression that is on hesitancy, obstructive warding, incomplete emptying, with the IPSS symptom score showing moderate to severe kind of situation. It is attempted to give them a proper medical therapy, graduate to the best possible optimization of therapy, and take it forward to the next level. Individuals who have got very large prostates, very juicy ones, who are quite otherwise having high blood supply, the way forward is to do a resection of the prostate in 35-45 minutes, clear them completely, leave the catheter for a few days to allow the external capsule area to heal well, and they do very well. But that small subset of individuals who are on catheter, and there are many such who are on the catheter club in this city of Mumbai and in cities across, prostate urethral lift by a popular name called Urolift procedure has revolutionized their life. In terms of, they can be catheter free. In individuals who have very high risk and cannot undergo a procedure and have a small to moderate gram prostate, could actually between 3 to 4 to 6 clips can be completely uplifted to a situation where their passage opens up, the occlusion goes away, and they continue to do well. For a younger class of patients in the late 40s, early 50s, and even 60s, who want to have a minimally invasive procedure for a smaller prostate, where laser doesn't stand very good because you have a lot of fibrosis when used for a very small prostate, and TURP plus bladder neck incision has been a gold standard choice. Individuals who don't want a very invasive surgery, get a minimal invasive surgery of a Urolift. So Urolift may have its own limitations of size. We don't choose patients beyond 55, 60, 70, 80 grams around. So choice is quite individual. It's quite understanding between a patient and a doctor as to where do we use a prostatic urethral lift. So over the last many cases who have undergone the prostate urethral lift, we have understood that there is always a progression towards the improvement of their technique, improvement of the way we have taken this forward in the last 6 months of newer changes that have happened. This has probably become a wonderful procedure for the right individual. So now in the era of prostate therapy, right from watchful waiting for minimal symptoms and smaller prostates to moderate symptoms on IPSS symptom score with significant improvement on medical management to patients who are not improving on medications and whose uroflowmetry continues to be poor, whose residual volumes continue to be high. Sadly, some of them land up with urinary tract infection. As a male, they should not get UTIs, which happens only because the bladder is obstructed. Taking them and understanding their bladder is most important. And therefore, before any invasive procedure, a urodynamics for individuals who look like obstructed on the uroflowmetry is a part and parcel of the protocol we follow at the Kokilaben Hospital in Andheri West here in Mumbai. That small subset of individuals which is gradually growing are those individuals who would do very well with a minimally invasive procedure, and prostatic urethral lift has actually stood test in right individuals. Both these patients at the age of 89 and 54 are doing extremely well over the last few months. In fact, the catheter was removed on the gentleman and 48 hours later, he complimented saying that you should have done this earlier. The 54-year-old gentleman who was actually taking his medicines for last 3 years and progressing towards obstruction chose Urolift as a procedure and probably got it as an understanding that this will probably occlude change completely, and therefore there'll be no occlusion as a result of the clips or the staples we apply to keep the prostatic urethra wide open. And doing so, because he's only 54, we would continue some medications towards continued shrinkage of the gland, which is a part and parcel of therapy by a urologist in view of progressive changes of hormone where prostate grows. So friends, minimally invasive therapy is walking in. There are many minimally invasive therapies which have come in. To choose the right minimally invasive therapy for individuals, Urolift procedure called the prostatic urethral lift, available at the Kokilaben Dhirubhai Ambani Hospital, in which I just quoted two examples to you of a very young and very elderly, quite fit and capable of undergoing any procedure, but chose the right procedure for himself, and a very elderly gentleman, completely comorbid, very high risk, getting recurrent UTIs, and sadly is on catheter. Important was to get his catheter out, to get him past urine better, and both of them actually had bladder outflow obstruction. So friends, we are looking at minimally invasive therapy for the right approach only. The right individual gets the right approach, and for taking it forward, Urolift has actually stood test of time with us. Thank you so much from the Kokilaben Dhirubhai Ambani Hospital, Department of Urology, for subscribing, coming onto the channel to take awareness forward, which out of a passion of the continued work that we do over last 2.5 decades, we continue to take it forward to the society, to individuals who matter. Thank you again.